So with us videotaping this, I've got this angled where you guys are not on the camera, so you're totally anonymous. But just understand that anything that you say will be on the camera and will be used against you in court. But just be prepared for that aspect, or be aware of that. So welcome. We may have a couple more people joining us. I got some texts from some people that were running late, so if they join us, we'll just welcome in and keep on going. Do you guys have any questions for me to start with? Anybody? Anything? Okay, that's excellent, excellent. All right, good smooth start. Couple things. Hopefully the projector will keep on working. If you guys don't mind, let's go ahead and silence our cell phones. I learned a long time ago that anytime I go to a movie or something, I pull my cell phone out and hand it to my wife, because I never silence it completely, so inevitably an alarm's going to go off or something's going to go off and disturb it. So it's probably going to happen in here too, and I apologize if that happens. As we're going through this is going to be some information that may be different than you guys have heard in the past, so it's going to bring up some questions for you. If you don't mind, write down your questions, because I've designed this where hopefully I've answered them all kind of in a logical sequence. So if for some reason there's a question that did not get answered when we're finished, I will answer some questions for you, and that gives me a chance to realize, okay, what do I need to add in, or what do I need to clarify? So if you guys would, just like I said, write down your questions, and then when they come up, we'll go over that. This is my personal email address. It should be on the business card with that little half slip of paper. So if a question comes up that I don't get a chance to answer for you, or if something pops into your mind on the way home or something, feel free to email me. Sometimes I may miss emails. I get about 200 emails a day. So a lot of times I'm going through and I'm deleting a lot of them just because they're junk mail. And sometimes I delete the wrong ones. So if I haven't gotten back to you in 24 hours, please resend it. I'm not ignoring you. I just deleted it or missed it. So. Okay, so I am a chiropractor. You guys go to chiropractors, familiar with chiropractic? Yeah, somewhat. Have y'all ever been to a chiropractor? No? Yeah, okay. So this is not a chiropractic seminar. You can go ahead and make that clear. But one of the questions I get a lot of times is, why is a chiropractor talking about thyroid and adrenal glands and diabetes and hormones and all these different things? So the best way to answer that question, and the best way to kind of start what we're going to be talking about, is to explain how I got to doing this kind of work. Okay, so I went to chiropractic school when I was 28 years old, is when I went up there and started. When I was 24, I had back surgery. So I came out of back surgery, I rehabbed myself, I did pretty well with it. Chiropractic was a large part of that. So I actually I had a degree in sports science, so I knew how to rehab myself, and I knew that I needed to use chiropractic with that. And then I went to massage therapy school. I worked as a massage therapist for a while, and that's how I got through chiropractic school, was working as a massage therapist. So I've got a background in a lot of body work. I went to chiropractic school to learn how to help people avoid back surgery, because that's what I thought chiropractic was: neck pain, back pain, and headaches, basically. When I got there, I learned that there's a lot more to it than just that aspect of it. Okay, so basically, the chiropractic theory is that your brain controls and coordinates the function of every cell in your body. That's a fact. That's not chiropractic. That's a fact. So if you cut your big toe, the brain controls the healing of that cut. Okay, so it controls all these processes. So the brain sends a signal to your body for your body to carry out function. And when this can happen, the body is said to be in a state of ease, or homeostasis. Okay, healing, balance. You're a nurse?
No, dental.
No. Okay. I see this crowd, I'm like immediately just want to kind of clear. So that's how the body is meant to work. Okay, the body is a self-healing organism. It is meant to overcome different challenges. So we get exposed to bacteria and virus every day. We have cancer cells that form every day. We have little injuries that happen every day, and the body overcomes these and balances itself. When we go out of balance is when we start having symptoms and diseases and things like that. So the chiropractic theory is that if the brain can't get a signal to the body because of what's called a subluxation, and what that is basically a bone in the spine that's out of place putting pressure on a nerve. Okay, so if a subluxation exists, that will cause the body to malfunction, because now the signal is not getting to the body the way it should. If the body is malfunctioning and this subluxation is not corrected and it goes on long enough, eventually you'll get into the state of dis-ease, which could be symptoms or it could be a disease process. So for example, I take my neck, I turn my neck like this, that's normal. I do something and I get a subluxation in my neck, and I turn, and now I can't turn any further, so I compensate. So that's the malfunction. I may not feel symptoms from that, but I have that malfunction. If it goes on long enough, I get into a state of dis-ease where all of a sudden I start having headaches or neck pain or something going down my arm. I get into that state where I become aware of this malfunction, okay? The body does everything it can to keep you functioning and keep you operating, so it'll hide symptoms from you. We've all heard of people who, just seem as healthy as could be, and then the next thing you know, they drop dead of a heart attack. Okay, that heart disease did not develop that night. It was something over years and years, but the body was just kind of overriding it and overcoming it. Okay, so that's the chiropractic theory. Based on that theory, if you have disease, it's because the brain can't get that signal to the body. So if you go in and you remove that subluxation, the body will regain function and will get rid of the disease. So the chiropractic theory from the olden days was you can cure disease by adjusting the spine. Okay, so when I went to chiropractic school with the intention of learning how to prevent neck pain, back pain, and headaches, I learned that, and I thought that was the coolest thing in the world. I'm like, man, we can cure disease with this. Because they would tell us stories, the old timers that were teaching would tell us stories that back, when they would adjust patients who had diabetes, adjust them once or twice, and they'd be healed. Thyroid disorders, cancer, all these different things, and they were curing these diseases by adjusting what they was telling us. So when I came into practice, I'm like, this is really cool. I'm going to heal the world. Why isn't everybody doing this? Okay, so I'm like, I thought I had found the secret key. Got into practice and reality kind of hit. And what ended up happening was, we did see the occasional miracle. I'd have a patient come in with low back pain. We'd adjust them and their constipation would go away. I'd have a patient with neck pain. I'd adjust them and sometimes their thyroid would kick in and they'd start losing weight. I've had patients come in, a lot of patients, with digestive issues and with low back pain, that when we adjust them and they're younger and they think they can't have children, they actually become more fertile and they're able to do that. We've had a lot of accidental pregnancies in our practice. So, disclaimer, anybody who is anywhere near procreation age, if you start getting adjusted or you start these treatment programs that we're going to be talking about tonight and doing this kind of work, you will become more fertile. And we've had patients in their 60s that have had scares when they've been working with us because they started, so. Don't get nervous. Yeah. So that's my disclaimer. I just put that out there. So overall, though, I wasn't treating patients for these clinical conditions. I was treating them for neck pain, back pain, and headaches. About 5 years into practice, I've got 4 children. One of my children started putting on weight. The other 3 were not putting on any kind of weight issues. Couldn't figure out what was going on with her. Started doing research, figuring out what was going on. We tried dietary changes, we tried all these different things, and finally I ran labs on her. And when her labs came back, she had Hashimotos. Okay, are you guys familiar with that? Okay. So basically autoimmune hypothyroidism. So the key with her was, this had been handled. She had been adjusted since she was an hour old. She literally got her first adjustment an hour after being born. So I knew that this was clear. But she still developed this disease process. So it's like, why did that happen? So I began researching because I did not want to put her on medication. At the time she was 12 years old. It's not going to put her on medication. So what I realized was at the time in doing research was that for the body to function, not only do you have to have the signal from the brain to the body, but you have to have the proper nutritional status. And she didn't have the proper nutritional status. And the reason she didn't, to kind of jump ahead a little bit, was she had some leaky gut syndrome that led into some autoimmunity that led her into the Hashimotos. But it was the metabolic status that was the issue. So I started thinking about patients, and the difference between patients today versus the patients of old, when the old timers that I was talking about were curing all these diseases, was those guys were still working on the farm, eating real food, eating whole foods with butter and fat and all these different things. They were eating actual food. We don't eat food that much anymore. We're the most calorically rich but starved nation that there is, because we eat so many things that don't have nutritional value. And so that nutritional status is a major issue. So when I started working with this with my daughter, we utilized functional medicine. And functional medicine is running labs. You design nutritional protocols around the labs, what you find is imbalances on those labs. And then you do this nutritional protocol, and then you can rerun the labs and make sure it's working. If it's working, great, keep doing what you're doing. If it's not working, you change it and you modify it. So it's objectively based nutritional protocols. And we did that with my daughter, and she did extremely well. She's 18 now, she's not on any medication, she's healthy, happy, graduated from college, she's doing great, okay? In an autoimmune condition that they're supposed to, once they have it, they always have it. but she resolved from it. So what I did was I was like, okay, she did really, really well with this when I combined that with the adjustment, so let's bring that into the practice, because I have a ton of patients who have, they're on levothyroxine or Synthroid or metformin for diabetics or hormone replacement therapy or whatever. So all these patients are on these things, so I started treating the patients with functional medicine and chiropractic. And the results were they were kind of okay. The younger patients, like my daughter, got well really, really quick. The older patients didn't. They got a little bit of improvement, but they didn't get a lot of improvement. So I'm trying to figure out why, kind of researching, studying what's going on with this. So one of the things that I knew is that metabolism is taking food and converting food into energy. That's basic metabolism, okay? I also knew that the brain weighs about 5% of total body weight, 5 to 8%. But then I came across a fact, and the fact was that in metabolism, the fuel that's created, the brain is extremely metabolically active, and it consumes up to 30% of all that fuel that's created. So the brain only weighs 5% of our body weight, but it consumes up to 30% of our fuel. So have you guys ever been so tired that you can't think? You're like, I am not going to make another decision, I'm going to bed. Okay, that is real. That is true. Neurological activity burns a ton of fuel. So if you have decreased quality of fuel, that means you have decreased quality of brain control or brain activity. And the difference between the younger patients that I was seeing with the metabolic aspect was that they had just started developing these problems. They weren't on thyroid medication, or they weren't having metabolic disorders for 5, 10, 15 years like these other patients that I was working with that weren't getting great results. So the difference was that their brains were not functioning properly, and I was assuming that the brain was functioning properly. So what we did was continue to study, and I started working with functional neurology. And functional neurology is where you do a neurological exam on a patient, you figure out where the neurology is not functioning properly, where the brain's not functioning properly, and then you use the theory of fuel and activation through neuroplasticity to restore those functions, and you rebuild the brain. So basically what happens is we use brain-based therapy to rebuild the brain. We use chiropractic and structural therapy to make sure that we remove this interference. Once the brain can get the right signal to the body, we make sure that we have the proper nutritional or metabolic status, and then that can continue through, and then the body will heal itself. So what we do, we don't treat thyroid disease here. We don't treat diabetes, adrenal fatigue, hormone imbalances. We don't treat any of that. We figure out where the breakdown is happening, and we support the body in recovering those areas and let the body finish its pathway, and then the body does the healing. The body's a lot smarter than we are. Okay? Does that kind of make sense? Ooh, I just broke my remote. But does that kind of make sense? Okay. So that's the approach that we take to treatment. So when we're looking at what we're going to be looking at tonight with the thyroid, we're looking at all of these aspects because all of this is important with its function. Okay? All right. So starting with the end in mind, number one, we have a DVD that I shot that's on the thyroid, and I'm waiting for these to come in. I've been waiting for a couple months to get these back in. But that little half slip of paper, if you guys leave that up front with Katie, when I get those in, I'll send those out to you. And that'll give you a lot of what we talk about tonight, and it goes into some more depth in some other areas. So, the other thing is we're going to look at what's called your web of physiological dysfunction. Okay, and that's what these questionnaires are for. So, what I want you to do is on your blank sheet of paper, draw a circle. That's Melissa, by the way. Draw a circle for me, and in that circle, write what you would consider to be your main motivating factor that brought you in. So is it fatigue, is it brain fog, is it weight gain, is it loss of libido? What is the main thing that brought you in? I'm going to put fatigue for today. Because a lot of patients like to focus on the symptom, like that's their motivating factor. And we're going to look at how that symptom may or may not be what we need to focus on.
But you do want us to put a symptom.
Yes, go ahead and put something in there. Yeah, whatever like if you had a magic pill that I could give you and it would take away one of your health complaints, what would the main health complaint that you would want to see gone be? And put that in there. Okay? All right. So this is a list of symptoms that a lot of patients with thyroid issues will suffer from. Now I'm going to stop talking about thyroid disorders, and I'm going to start referring to the thyroid metabolic pathway. And you'll understand why as we go through this, but it's a very important distinction. Everybody thinks I have a thyroid problem. And the fact of the matter is most patients who have thyroid diagnoses don't have a thyroid problem. Okay, and that'll make sense as we go. So common symptoms: fatigue, headaches, depression, brain fog. Those are all brain-based symptoms, okay, the neurological system. Then we've got constipation, stomach aches, gas, bloating. That's the digestive system. Okay, so we have the neurological system and we have the digestive system. We have cold intolerance, muscle cramping, weak muscles. A lot of patients will have like fasciculations and shaky muscles and tremors. That's the musculoskeletal system. We have getting sick easily or being a slow healer. A lot of patients will have like a subclinical bronchial thing where they're always phlegmy. They wake up in the morning and they have a lot of sinus and phlegmy things. That's the immune system. Dry, brittle hair, itchy skin. The lateral third of the eyebrows will start to diminish. That's the integumentary system, the hair, skin, and nails. Night sweats, PMS, cramping, hormone imbalances. That's the endocrine system. The reason I put these up here is because those are all of the major systems of the body. You have the nervous system, digestive system, hormone, endocrine system, integumentary system, musculoskeletal system. These are all major systems in the body. And what that means basically is that if you have a thyroid metabolic pathway disorder, it's going to affect everything in your body because every cell in the body has a thyroid receptor on it. So if you have a pathway issue, it's going to affect the entire body. And that's why patients with these thyroid disorders have such a broad spectrum of symptoms. Okay, does that make sense? Okay, so how does the thyroid work? This is where we get into the fun part of this. Doesn't this sound thrilling? Just that? Wait, before we do this, I have to tell you a joke. Okay? Okay. First joke is, what did the avocado say when he looked in the mirror? Yeah, you ready to know that one? I may be fat, but I'm a healthy fat. Okay. Okay, so I love to go to seminars where they tell jokes. And this guy, I was in a seminar, there was like 10 of us in this room, and it was like an executive plaza, so we had this long table we were all sitting at. It wasn't like a big hotel room. And he told this joke, and when he told the joke, everybody in the room started cracking up, and I did not get the joke. I was like, what the heck, you know, so I'm stopping everybody on the break, explain this to me. So I kind of became the butt of the joke too, because, or the brunt of the joke, because I didn't get this joke. So everybody started kind of messing with me on that. So I've been telling the joke in these workshops, and I've been doing this for 5-6 years now, and nobody has been able to explain this punchline to me. So I'm going to tell you the joke. If you can explain it to me, please do after we're finished. Deal? After we're finished, yeah. Okay. All right, so there's this guy. He's an engineer, and he decides that he wants to build a barbecue pit. And he goes out in his backyard, and he levels it out, and he knows exactly how big this barbecue pit's going to be, how big the grill needs to be, how many bricks he needs. He figures all this stuff out. So he goes to Home Depot, and he starts loading up his cart. He gets all of it, all the stuff that he needs. All he needs to pick up now is the bricks. So he finds a sales clerk and he says, I need to get 149 bricks. And she says, that's great, because we sell them in pallets of 150. And he says, well, I don't need 150, I only need 149. And she says, well, I can't sell you 149 single bricks. You're going to have to go ahead and buy the pallet. Well, he kind of gets mad, and he's like, no, I don't want to pay for that extra brick. She goes, well, sir, you know, you might have made a mistake. Maybe you need an extra brick. And that just made him mad. He was like, I did not make a mistake. I knew exactly what I was doing. So they argue back and forth. Finally, he decides he's going to buy this pallet of bricks. So he buys the pallet of bricks, goes home, unloads it, builds his barbecue pit. It's perfect. He's patting himself on the back. It's exactly what he expected it to be. He looks over and he sees that brick on the ground, and he starts getting mad. He's like, I knew I didn't make a mistake. I knew I wasn't going to break one. I knew that I had measured this properly, and I had just wasted money on that brick. That's only, what, $3? But still, he's kind of upset about this. So he bends down, he picks the brick up, and he's looking at it, and he's thinking about that sales clerk accusing him of making a mistake, and he's getting more and more angry. Finally, he just yells at the top of his lungs. He rears back and he throws the brick as hard as he can up in the air, and the brick never comes down. And that was the joke. So, I don't get it. So if you guys get it, please, like I said, afterwards explain that to me. I thought the avocado joke was good though, right? Yeah. Okay, that was better than that one, wasn't it? Yeah. Okay, so how does the thyroid gland work? All right. So we have, I'm going to clear out some of the space here. All right. So we have our thyroid gland. Did you get the joke?
No.
No? Okay, I hear you laughing. I'm like, oh, cool, I'm gonna get this. All right, so you have your thyroid. Now, I have a major disclaimer. I get to writing very, very quickly. And I don't usually wear glasses. I'm trying to get used to these, so I don't see what I'm writing. So if I misspell words, I'm just putting them up here. So just listen to what I say, not what I write. Okay. So your thyroid gland produces T4 and T3. So if you have low T4, thyroid hormone, the hypothalamus, which is a part of the brain that picks up on the environment, okay? So if it's daytime outside, the sunlight permeates through, goes into the pineal gland goes to the hypothalamus. Hypothalamus says it's daylight, you need to be awake. That's why if you're looking at blue light before you go to bed on your iPad or whatever, it's hard for you to go to sleep. So this picks up on the sleep-wake cycle, day-night. Also picks up on body temperature. If you have an infection, it'll raise your temperature to fight this infection. Okay, the hypothalamus controls that. It controls your appetite, it controls your sexual desire, it controls all the different functions in the body. So if it picks up on low T4, it sends a signal called thyrotrophin releasing hormone to the pituitary gland. Your pituitary gland will then increase the production of thyroid stimulating hormone, or TSH, which will stimulate the thyroid to release T4 and T3. Okay? So what does this mean? Let's say you go to the doc and you're like, Doc, I feel like I have my thyroid issue. I Googled it, and the Googler says that, you know, I'm going to have fatigue, weight gain, brain fog, can't lose weight, all these different things. And I'm having all these things, I think I have a thyroid issue. So he runs your labs for you. He runs your labs and they come back and you have elevated TSH. So that tells him, okay, you have high TSH, that means you have low T4, so you have hypothyroidism. Okay? So he goes through and he puts you on Synthroid or levothyroxine, okay, to try to support this. So Synthroid and levothyroxine, so I'm going to put S and L, those are synthetic T4. So that causes your T4 to rise to a new normal level. That causes a signal to go back to the hypothalamus. It's called an inhibitory feedback loop. So that causes the hypothalamus to stop the production of thyroid releasing hormone or thyrotrophin releasing hormone and to bring TSH into a normal range. Okay? So taking that Synthroid causes this loop, so it causes everything to come back into normal. Or causes actually your TSH to go to a lower level. So they usually put you on enough to get that TSH really low. Okay? So that's the normal metabolic pathway. Okay? The catch is, we see patients all the time that are on Synthroid or levothyroxine or Armour or Nature Thyroid, whatever they're on, and their labs look like what their doctors want it to look like, but the patients still feel really, really bad. And so the question is, why is that? If their labs are normal, why do they still feel so poorly? Why are they still having thyroid issues? Well, the reason for that is because this is a very small part of the whole process. Remember I said I was going to talk about the thyroid metabolic pathway? This is a very small part of that. So, your T3 is about 7% of what the thyroid makes, okay? This is the active form of the hormone. So, if I want a cup of coffee, I'm going to go to my coffee supply place, whatever, Keurig or whatever. I'm going to get my ground up coffee beans, I'm going to put them in a filter, I'm going to run hot water through it, and I'm going to get a cup of coffee. Those coffee beans are ready to be used. I can use them to make coffee. That's like T3. T4 is inactive. So this is 93% of what the thyroid makes. So this is a situation where I go to make that coffee, but instead of getting ground up coffee, I get coffee beans. And I put those in my coffee filter, and I run hot water over those. I might get some brownish water, but it's not going to be coffee. All right, that is not ready to be used. So that's what T4 is, and that's 93% of what the thyroid makes. If you're on Synthroid or levothyroxine, that's T4. The body cannot use it. It has nothing to do with your total metabolic output. So what happens, this will go into the cells, assuming that you have the nutrients required to get the T3 into the cell, and you'll create metabolic output here, which is adenotriphosphate. That's 7%. This 93% has to be processed, and this is where the problem comes in. Number one, it has to get onto a substance called thyroid binding globulin. That's like a taxi cab. So T4 gets onto thyroid binding globulin, and it goes out to the liver, to the gut, to the kidneys, and to all the other tissues in the body. And this is where we get the conversion of T4 to T3. So this back end here is where you have 93% of our output, or 93% of our fuel creation. So if there's a breakdown in T4 getting onto thyroid binding globulin, you're going to have decreased metabolic output. If there's a breakdown somewhere in the liver, the gut, the kidneys, or some of these other tissues, you're going to have decreased metabolic output, even if you have totally normal labs. Okay, does that kind of make sense? All right, so that's the problem, is that the focus is usually on this area of the pathway, and it ignores all the conversion of T4 to T3, and that's where patients get into trouble. So a patient will be on the medication, their labs look normal, they'll go back to the doc, he runs their 90-day labs are right where he wants to see them, but they're still having these hypothyroid symptoms because this pathway is not putting out enough metabolic output. So since the labs look okay, the doc's like, okay, well, there's got to be something else going on here. We need to look at antidepressants or so on and so forth. And I see a lot of patients who are on thyroid medications and antidepressants because it gets to the point where they think it's in their head. Okay? So that's the metabolic pathway. Now, we're going to get into how this breaks down and what to do about it. Okay? So levophysiological dysfunction. The first thing we want to do is, if you got to the last page, and I don't know why I haven't switched these because this is always the first page I cover, but if you got to the last page and circled all the yeses and nos on that, do me a favor and count how many yeses you circled and write that number on the bottom of your page. Okay, everybody have your number?
No.
No?
I didn't get a chance to film.
Oh no, that's okay. Just you can kind of take notes on it, yeah. Okay, but you guys all have your number back there? Okay. So those questions are all based on changes that have happened neurologically. All right, and it's normal as we age a little bit or stress or things that we're going to have some changes that happen. So on that questionnaire, we allow for 5 yeses to be considered normal. Okay, so if you had more than 5 yeses on that, then what you're going to do is you're going to go to your circle that I had you draw, and this is going to be the beginning of your web, and you're going to draw a line and you're going to write the word brain. Because if you have more than 5 yeses on that, that tells me there could be a brain-based issue going on. Okay, so what do I mean by brain-based issue? Well, we look at a couple areas. First area we look is the frontal lobe. Frontal lobe is our judgment, it's our planning, it's our decision making, our social skills, things along those lines. Got a great story that as an example of frontal lobe dysfunction. I had when I was 13, we lived in Panama, Panama Canal, not Panama City. And one day, family decided we were going to fly over to a different part of the country and go up in the mountains and explore. So we're sitting on the runway waiting to take off, and this was back in the 80s, and this was in Panama. So the plane was like a little prop plane. There was like maybe 13 seats on the plane. The windows were those kind of windows where you kind of bus driver it down, you know, push it in and slide them down. So we all had our windows down, we're waiting to take off, it's hot, it's humid, we're all sweating. Finally, the stewardess, for lack of a better descriptor, she goes over and she pulls up the stairs for us to go ahead and take off. Well, when she's doing that, I could hear a commotion. And I could tell that she reopened the stairs because you could see the light kind of come through. And when she did that, this man is yelling. And the plane does this, it goes like this as he's walking up the stairs. I'm like, okay, it's interesting. So he turns the corner, and it was this Panamanian guy, okay, just stinky, sweaty, like armpit, like just drenched in sweat, breathing heavy because he'd obviously been running trying to get there. Very, very heavy man, smoking a cigar. He has cigars in his pockets. He gets on the plane, he's smoking a cigar. He's walking through the plane and he's bumping into everybody trying to find a seat. Well, we're running late at this point, so as soon as he gets on, she pulls the door back up and closes it. So the pilot starts going. Completely different rules there than we have here. So the pilot's going, he's getting bounced around trying to find a seat. And there was this lady that was sitting like 3 rows in front of us, and she had a poodle sitting next to her. And he stops and he says, he's, lady, move your poodle, I'm going to sit there. And the lady's like, I'm not moving my dog, I paid for this seat, the dog, and she didn't want to sit next to him, you know. So he's like, move your poodle, because we're taking off and he's getting all bounced around and everything. So he's starting to get really irritated. And they're arguing back and forth, probably get 5 or 10 minutes doing this. Finally, he gets mad and he grabs the dog. And the lady grabs the dog, and they're wrestling over this dog. And he kind of takes the lady and kind of puts her down and throws the dog out the window. Yeah. So first of all, I'm 13, so at first I'm thinking, cool, fight. Well, that's wrong. But then when the dog goes out the window, I'm like, oh, this is horrible. So the lady freaks out, grabs the cigars, throws the cigars out the window. Finally, the stewardess comes and breaks him up and takes him back and makes him sit down. So I'm looking at this lady, and she sits down, and she's like, oh my God, my dog. I can see that she's kind of freaking out. She looks out, and I look out the window, and the dog is on the wing of the plane. And his ears are flapping, and he's like hanging on. And guess what he had in his mouth? The brick. I know, you were cracking up too much. I'm like, there's something wrong with her. She's laughing about that. So, So I tell this story. I actually did get, a friend of mine tricked us all at dinner one night with that joke. But I think it's a really good example of frontal lobe dysfunction. So the guy that was running late, number one, his planning. He was late getting there. His social skills were hideous. His judgment was hideous. His decision making was hideous. Okay, so you will never forget what the frontal lobe does now. Okay, so that's frontal lobe. Now we'll see that in kids. Kids will come up to you and say whatever they're thinking. I don't like your shoes. I don't like your pants. You know, Mama, why'd you do your hair like that? You know, things like that. We don't fully develop this frontal lobe until we're about 25 years old. That's why teenagers are so dangerous. They have all these hormones, and they don't have a lick of sense to go with them. So
There's hope still.
there is hope. Yes, yes. I've got two of them, and yeah, there is hope. My 18-year-old, she's phenomenal now. She really, you know, I say 25, but she's come in her own really, really quickly. So there's hope. I know it took me until 25, but that's when I look back and say, okay, I became a good person at 25. That's what happened. So that's on the front end of life. Now, what happens is on the back end of life, we can start losing these functions. So you may know parents or grandparents who maybe as they got older, they got less socially aware, they got more rude and more harsh in the things that they say. Now, some of that could be they were just tired. Some of it could be that they lost the ability for this. I see people all the time that they can't make a decision at all. Like part of their therapy is we have them practice making decisions because they lost that decision-making ability. The problem is when you start seeing this happening, number one, even when you're older, because it doesn't have to happen, but when you start seeing this in 30-year-olds and 35-year-olds and stuff, because they've had these metabolic disorders. And I see patients all the time, late 20s, early to mid 30s, that are starting to lose this frontal lobe function. And they don't have patience with their kids, they don't have patience with their husband, they're just irritated with everybody, they're crotchety all the time, they're just not happy. And a lot of that comes from this, okay? So that's frontal lobe function. Parietal lobe, one of the main functions of the parietal lobe is pain sensations. So I take a hammer and I drop it on my big toe. First of all, that's a bad decision, so that's a frontal lobe disorder. But if I do this, I have this hammer hit my toe, the signal from my toe comes up, hits the mesencephalon on my right side, crosses over and goes to my left parietal lobe, and my left parietal lobe says, boom, that hurts. Sends a signal back down, comes down, and my toe starts to throb. So I feel the pain in that toe because of my left parietal lobe. Remember, the left brain controls the right body. So that's normal, that's supposed to happen. But let's say we're 2 weeks down the road. The toe is healed, the inflammation's gone, the tissue's healed, everything is fine. But I still have an aching in that toe. Sometimes if the brain has gone awry, once that parietal lobe is signaled and starts firing, it doesn't stop. So a lot of patients with chronic pain syndromes have parietal lobe dysfunction. So when we start working with them, we start balancing the brain, a lot of times these chronic pains start going away that have been bothering them for 10, 15, 20 years. So that's one of the main things for the parietal lobe. The other thing is proprioception. So my right eye is closed, I cannot see my hand. I know that I'm about to hit the chalkboard. I know where my nose is, I know where my knee is. And I can touch it because of that parietal lobe knowing where my hand is in space and time. So another way you'll know is if you have dysfunction on that is if you tend to knock things over a lot, like if you're reaching for something, or if you get up in the middle of the night and the lights aren't on, you have a hard time balancing and you're walking into walls and things like that, that could be parietal lobe. And it could also be some cerebellum. Okay, so that's a parietal lobe. Temporal lobe. Ever go to Walmart and walk out and can't find your car? Ever go to Walmart, walk out and can't remember what car you drove? That's severe temporal lobe. I went to Walmart one time, we were getting ready for a football game, and so I went in to get those confetti poppers, because my son, that's the only reason he likes to go to the games. We go to the Niceville games when they score a lot, so he can shoot those a lot. And I walked out of Walmart and I had this big old bag of these poppers, and I'm walking around. Couldn't remember what car I drove, I couldn't figure it out, because when I was driving there, I had a really stressful conversation. And was not even paying attention to that aspect of it. So when I got out in the parking lot, I'm like, what am I, which button should I be pushing, trying to find the car, and where did it, so I'm trying to picture the dashboard when I was driving in to figure out which car it was. So that happens quite often. But that's temporal lobe. Sometimes you can't find the words you're looking for, that would be temporal lobe. You walk into a room, can't remember why you're there, where you put your keys, things like that, those could be temporal lobe related, okay? Deep to the temporal lobe is a part of the brain called the hippocampus. And that's where you start getting into dementia and things like that, more of the long-term memory loss. So you want to stop it when it's just here, and a lot of that has to do with cortisol levels, which we'll get into. So we also look at the occipital lobe, the different parts of the brain other than this, but these are the main areas that we look. And what you do, this is functional neurology, that's what I was talking about. And we use fuel and activation to resolve that. So basically, long term, we use metabolic therapy to balance the metabolism and everything that we're going to be looking at. That's the fuel. In the short term, while we're doing that, we use oxygen therapy. So we have patients come in and we use oxygen to hyperoxygenate the brain to get it ready to fire. And then we have you doing exercises to activate the parts of the brain that are weak. And then through neuroplasticity, the body can actually rebuild those pathways. And it's really, really cool to watch it happen. You'll see patients that start treatment with us, and they're very downtrodden, very depressed, and just their face just looks like they've given up. And by the time they're finished, it's like they have color back and they're smiling and they're happy, and you can get their old personality back. And it's really, really fun to watch that happen. And we had this one patient come in, and we knew she was progressing because it went from, hey, she wore sweats today, she got out of her pajamas. And the next day it was like, oh my goodness, she wore jeans today. And the next it was like, she started putting makeup on, and we just could see, we could track this progression of how she became more, and by the end she was a totally different person when she started. And it was because we were able to rebuild the brain function. So it's really, really cool to watch. Okay, now we're going to switch over to the questionnaires that you had where you actually circle in the numbers. Okay? So category number 1 is the colon. So if you circled any 1s, 2s, or 3s in category 1, then on your web of physiological dysfunction, you're going to write the word colon. So again, that's any 1s, 2s, or 3s in category 1, and you're going to write colon. Because what that tells me is that there are symptoms with that organ system, and there might be something going on there. And while you're there, go ahead and look at category 2 and 3. Same thing, if you circled any 1s, 2s, or 3s in there, you're going to write the word stomach. And category 4 is small intestines. So any 1s, 2s, or 3s in category 4, you're going to write small intestines. Okay, so what does this mean? Normal digestion, the way that this works, is food comes down the esophagus, it goes into the stomach. When the food enters the stomach, the body produces hydrochloric acid to break that food down. Your liver detoxifies your blood, and it forms bile. Bile is then stored in the gallbladder, and then the gallbladder, when the food exits the stomach in the presence of the hydrochloric acid, the gallbladder squeezes and puts bile in there to help break down the food. Okay, that's a normal digestive process. So, if you have 1s, 2s, or 3s in category 2 or 3, I'm sorry, I haven't used my cheat sheet. Yeah, category 2 or 3, what that tells me is that your stomach is not working properly, you have decreased hydrochloric acid levels. Okay? What does that look like clinically? When you eat, you kind of get gassy and bloated. Acid reflux is actually too little stomach acid most of the time. So a lot of patients, when they have acid reflux, what's the first thing that they do? Like if you had reflux, what would you do? Would you go take Tums, or you're gonna do you know if you guys suffer from acid reflux? Beautiful. Well, never mind. Y'all know what the heck they're gonna do then. A lot of times, patients will start taking these antacids to try to reduce that. And the problem with it is it's actually too little acid, because what happens is when the food's in here, if you don't have enough hydrochloric acid, the food sits too long and it actually starts to ferment. And when it does that, it regurgitates back up into the esophagus and causes reflux. So that's one of the symptoms. Other symptoms will be gas, bloating, things along those lines. Okay? So that's hydrochloric acid. That's categories 2 and 3. Category 4 is small intestines. So basically when the food exits out into the small intestines, what happens is your small intestines are made up of a bunch of different cells kind of butted up against each other. So I want you to imagine with me that your digestive tract going from the mouth into the esophagus, into the stomach, through the small intestines, through the large intestines, and out is actually outside of the body. Okay, I know it's a tube that runs through the body, but it's actually keeping things out of the body. So we're going to use this pen cap as an example. So I swallow this pen cap. It comes in, goes into the stomach, hydrochloric acid acts on it, tries to break it down. It's not going to break down very much. Then it's released into the small intestines. So it goes through the small intestines, it never gets through, goes into the large intestines, and comes out in the feces. Okay? It's a filter. Your digestive tract is a filter. It keeps things out of the body that shouldn't be there. Okay, that's the way it's supposed to work. If you have food sensitivities, if you have decreased hydrochloric acid, whatever the reason is, if it's just systemic inflammation, If you have 1s, 2s, or 3s in the small intestines, what that tells me is that the small intestines have actually become inflamed, and so these tight junctions start to open up. So as food comes down, it's supposed to digest, it gets smaller and smaller. When it gets small enough, it goes into the blood supply and gets assimilated for nutrients. But if you have this opening up, then these bigger proteins that shouldn't be there will actually start leaking into the blood supply. And now when that bigger protein gets in the blood supply, that's an antigen. The body that's not supposed to be in the body. Just like if this cat got through there, the body would start making antibodies to try to destroy it. So now you have this protein there that's not supposed to be there. So this is what happened with my daughter. Okay, so she had, when she was 2 years or 4 years old, we were in chiropractic school in Texas. And my wife had my daughter and my son out in a field out at the apartment complex we lived in. And she turned around and did something with my son. My daughter started screaming. She turns back around and she had crawled into a red ant bed. And it was a Texas red ant bed, so these were significant ants. To this day, she cannot stand ants. Like, if we want to mess with her for Halloween, we'll put a big ant on her pillow. Just kind of, we're mean, but you know. So, but I think what happened was she got that toxic overload, and that led to inflammation in her GI tract. And that's what led to these proteins leaking out, which then led to antibody formation, which morphed into thyroid peroxidase antibodies and started attacking her thyroid gland. And that's how she developed Hashimotos. So for her, what we had to do through the functional medicine was we had to stabilize the gut, get rid of this leaky gut syndrome. We had to calm down the immune system. And then once we did that, her thyroid was absolutely fine. It was not a thyroid issue at all. It was an immune system and a digestive disorder. And that's what we find with the majority of patients that come into us with thyroid diagnoses, is that they don't have a thyroid issue. It's usually something else that's causing the issue for them. Okay, so that's the small intestines. That can lead to leaky gut syndrome. So you've got the digestive tract getting into the small intestines, and then after the food goes through all the wiggling and winding of the small intestines, it comes out through the large intestine, which is your colon, which is category 1. Okay, so that's the digestive tract. Now, along with all of these functions, when you take those 4 areas and you put them together, that forms the gut. So not only are you dealing with, if you have any of that, dealing with digestive issues, but it's also going to be a conversion factor of T4 to T3. Also, the gut is about 60% of our immune system and about 80% of our serotonin production. So a lot of patients with depression issues have gut-based issues. And one of the things that we see with patients is once we start healing that gut, their depression issues start to clear up and then start to go away. Okay, does that make sense? Okay. All right, so category 5 is liver and gallbladder. So we already talked about the liver, it detoxifies the blood and so on, and it stores the bile in the gallbladder. There are 4 of you guys in here, and I don't want you to raise your hands, but statistically 1 to 2 of you don't have a gallbladder. There's some patients that come into these workshops and that we see in the office, so it's usually about 25 to 50% depending on where we are. So if you don't have a gallbladder, or if you know somebody that doesn't have a gallbladder, they need to be on bile salts. Okay, that's bile salts. And what those do is your gallbladder stores up bile, and when the food exits the stomach, the bile squeezes in and starts to digest the foods. If you don't have the gallbladder, you don't get that impulse of bile, so it's just a trickle. So your fat-soluble vitamins, your omega-3 fatty acids, if you're taking these supplements to try to reduce inflammation, all these things won't get digested because you don't have enough bile there. So if you take those bile salts, it'll make up for that. It'll help with digestion. It'll change the digestive pathway. So again, if you know anybody in that situation, have them get bile salts. It'll change your digestion. Okay, so that's liver and gallbladder. Liver sits right here. So the gut and the liver together, that is 80% of the conversion of T4 to T3. So if you have 1s, 2s, or 3s in the categories 1 through 5, that means you probably have liver and gut issues, which means that you're going to be underconverting, which means you're going to have hypothyroid symptoms. No matter what you do medicinally over here, no matter what your labs look like, you've got underconversion factors going on here. Okay? And that is what we see in the majority of patients, that for whatever reason that's caused that liver and that gut disorder, they're not converting the thyroid hormones. Okay? All right. Category 6 and 7, blood sugar. So we have a normal blood sugar range. Okay? We get hungry, we eat, blood sugar comes up, and then we come back down, we get hungry, and we eat again. So that's some normal blood sugar regulation. If you have 1s, 2s, or 3s in category 7, what that means is that when you get hungry and eat, your blood sugar goes too high. Okay? If you have category 6, that means that when you come down, instead of stopping here, your blood sugar goes too low. All right, so what does that look like? Y'all have seen the Snickers commercials where they talk about being hangry, Roseanne Barr, different things like that. That's where you get that hypoglycemia and your personality changes. You get mad, you get irritable, you get shaky, all these things go on. You eat a Snickers and it saves your life. Okay, I'm not saying go eat Snickers, but it can be helpful. So that's hypoglycemia. Now, do any of you have both 6 and 7?
Yep.
You do. Okay. So what that is, that's dysglycemia. That's where you're going up and down. This is an absolute deal breaker when it comes to healing. If this is going on, your body will not heal until you fix it. This is our #1 priority. And the reason for that is because this is pro-inflammatory. When your blood sugar is doing this, that means that your blood becomes like a blowtorch. So it's going to cause any aches and pains to be worse. It's going to cause the blood-brain barrier to open up, and now this inflammation gets in and starts affecting the brain, which we already talked about that. This has to be fixed. Okay, that is a deal breaker. And the reason that happens is because if it's gone on long enough, the body, well, first of all, this can happen for a period of 10, 15, 20 years before your fasting blood glucose starts to rise. So even if you're getting your labs done and your labs look fine, that's because your body is still able to maintain homeostasis when you get into that fasting state. But when you're eating, your body's doing this. Okay? And again, that'll tear your body up. So that's got to be fixed. Now, when you combine that with the adrenal glands, are you guys familiar with the adrenals at all? Okay. So the adrenal glands are your stress hormones. You're walking in the woods, you see a bear, the bear charges at you. Okay. First thing that happens is your digestion shuts down because your parasympathetic nervous system gets shut down. The blood rushes out to the muscles, your hair stands up, your pupils dilate, your heart starts beating, and you get ready to fight or run from that bear. So what happens? What's that?
Better run.
Better run, yeah. And don't climb a tree. I have learned that.
Faster than the other person.
Yeah, you just don't have to be the fastest. You just got to be faster than the guy next to you. That's it. Yeah, I used to say, you run, you climb up a tree and everything, and there was a hunter, and he was like, no, don't climb a tree, bears can climb. I'm like, oh yeah, I didn't think about that. I should got to stop giving that advice. So, but anyway, you have a physical response. So basically, you have a stressor, your hypothalamus sends a signal to the pituitary, which then signals your adrenals to release epinephrine, norepinephrine, and cortisol. So when these hormones are released, you run or you fight or you do whatever, you outrun your friend, however you have to survive this thing, but you have this physical response that burns off these hormones and you go back to a normal state. That's normal, that's natural. Let's say you get up in the morning and you say goodbye to the family, have a cup of coffee, give yourself a little adrenal boost there. You go to work and you get to work and there's this huge stack of paperwork on your desk and it's just immediate stress. So you get a stress response, you get that release of epinephrine, norepinephrine, and cortisol. You sit down, you start working on it, everything kind of, you're getting better, but you're not burning off these hormones, so there's no physical response. And then your coworker comes in and puts a new stack of paper on there. So that's another impulse of this, and it just keeps on going. So if you end up having chronic stress, what will happen is your category 9, you'll start showing symptoms in there, because you're having chronic stress, so you're having chronically elevated cortisol and adrenal hormones. If this keeps on happening and keeps on going on, then what ends up happening is your liver produces cholesterol. Cholesterol converts into pregnenolone, which converts into progesterone, which converts into cortisol, DHEA, testosterone, and estrogen. So if you're under a lot of stress and you have high needs for cortisol, your cholesterol is going to go up. Okay? Because you got to try to produce more to meet this demand. So your cholesterol is going to start going up. Also, if you have that blood sugar issue I was telling you about, then what happens is your blood becomes acidic. So if your blood becomes acidic and becomes damaging, it can damage the arteries. So what does your body do? Your liver mobilizes cholesterol to protect the arterial lining. And so now you have that protection against that acidic blood. So blood sugar dysregulation will also cause increases in cholesterol. So what happens if you have increased cholesterol when you go to the doc and they run your labs? What's the first thing they're going to do?
you on medicine.
Put you on medicine, okay? So they're removing your protective barrier, so now your arteries are open for that damage. They're removing your body's ability to create the hormones necessary to keep up with stress in daily life, which is going to put you into adrenal fatigue, okay? Excess cholesterol, 9 times out of 10, is a blood sugar dysregulation issue. Blood sugar goes directly into the adrenal glands as well. We see patients all the time with excess cholesterol, and it drops 20, 30, 40 points. I had a guy drop 170 points in a 90-day period just by handling blood sugar. It happens all the time. If you get blood sugar under control, 9 times out of 10, your cholesterol is going to be fine. Okay. Also, if you push your cholesterol too low with medication, then you get into situations where now you can't make enough hormones and the brain doesn't work properly, and then you get into depression and so on and so forth. So there's a lot of effects that come in when you take these statins. I'm not anti-medication, but that's one that I don't really like. Okay. Okay, so we have high adrenal function. Now, if the adrenal glands keep going, eventually they can start to wear out because the stress just gets to be too much. So it's kind of like if I picked up a 20-pound dumbbell and I started curling it. You know, I can sit here and do it 500, 600 times. Just kidding. I can, probably about, 10, 15 times I'd be fine. About number 16 or so, I'm going to start getting tired, and it's going to start going a little slower. You start hitting about 30, and I'm going to have a hard time, moving that dumbbell. The bicep is still putting out 100% of the effort, but it can't get the outcome. So if you have chronic stress, the adrenal glands are still working really, really hard trying to keep up with the demand, but they start to fatigue, so your levels start to drop. And that's when you get into category 8. So if you have symptoms in category 8 and category 9, that tells me that you're at some level of adrenal fatigue, that you've been under chronic stress to the point that your adrenal glands are starting to fatigue. And when that happens, when your adrenal glands are getting fatigued, then 2 things happen. Number 1, there are 2 kinds of stress on the body. There's a eustress, which is good stress, and there's distress, which is bad stress. Eustress is things like working out. It's a stress in the short term, but it makes you stronger. Even if it's a good stress and you have adrenal fatigue, when you start trying to do that, you're going to crash because the adrenal glands can't handle that stressor. So when we start working with patients and we're working on the brain-based therapy and the metabolic and everything, we have to look at what their metabolic capacity is, because a lot of times patients are in adrenal fatigue and we can't move too quickly or they're going to end up crashing. So we have to work with that and modulate that. And patients have to do that as well. Like if you start an exercise program or something like that, you've got to do it at the level you can handle and build up that tolerance level as you heal. Okay? So that's number 1. Number 2, if you have this adrenal fatigue happening, then your body starts to really siphon to try to keep those cortisol levels up, because that's a life-sustaining process. So when that happens, your progesterone, your testosterone, and your estrogens go out of balance. So then you end up with hormone dysregulation. If your progesterone drops and your estrogen even drops, but your progesterone drops more than the estrogen to oppose that estrogen, you will be considered estrogen dominant. And when that happens, estrogen loves to bind to thyroid binding globulin, which will block T4. So that can be another reason for hypothyroid symptoms, which have nothing to do with the thyroid gland. So like if you walked in and you had a hypothyroid diagnosis and you had one and you had one, you're all on Synthroid, and I go through and I say, okay, let's analyze this and see what's going on. And for you, we find out that you're really, really stressed out, you're into adrenal fatigue, and because you're in adrenal fatigue, what's happened is you've got this cortisol steal going on, so you're in estrogen dominant, so your thyroid binding globulin is being blocked. It's a completely different treatment protocol than for you who has food sensitivity. You've been eating these foods, you've developed leaky gut syndrome, which has led to this autoimmune response, which has led to the thyroid gland being attacked by thyroid peroxidase antibodies, which is Hashimotos. It's still hypothyroidism. Completely different protocol, and for you, it's a matter of the fact that you have liver and gut disorders, so you can't convert T4 to T3. And that's the key, is to get away from labels, because if you treat just based on a diagnosis, you don't get to the cause of what is that diagnosis. And if my daughter, if I had taken her to the doctor, again, I'm not anti-doctor, so I don't want this to sound that way, but if I had taken her and gone that traditional route, she would be on Synthroid or Levo at this point. Heck, we'd probably be trying to figure out how to balance her thyroid, because at this point she would have been on it for 5 or 6 years and she'd be out of balance. Okay, so it's a matter of getting in there and fixing what's the cause. Category 10 and 11, those are the thyroid. Oh, we stopped writing our stuff up here. So anyway, you keep on writing those things. 10 and 11, that's your thyroid gland. And again, that's not the thyroid gland, that's this thyroid metabolic pathway. So if you have any 1s, 2s, or 3s in there, you're going to write thyroid up there. 12 and 13, that's your pituitary gland. It sits right here. Most of the time, that is not a cause. Most of the time, the pituitary gland, when that starts going awry, it's because of all this other stuff that's going on. Okay? Category 14 and 15. Okay, so if any of you ladies filled out category 14 and 15, all right, I'm going to restate that. If any of you ladies filled out category 14 and 15, you have a brain-based issue. Yeah, we got one. Yeah, we got a winner. There are some very clear questions in there that would indicate that you're in the wrong area.
But I have legs too.
Yeah, you do have legs. This is true. So 14 and 15 are the male hormones, 16 and 17 are female hormones. And those, again, 9 times out of 10, that's going to be adrenally related. I'll give you guys a great example. I had a patient that came in. She was mid-30s, and we did her evaluation, we did her labs and everything with her, and the only thing that I could find wrong for her was adrenal glands and blood sugar. So it was this area down here. She comes through treatment with us. She is, it takes us about 6 months with her. Most patients I work with about 3 months. This one was tough. For some reason, we had a hard time getting her body to come back into balance. 6 months later, she's there, everything's good, we release her from treatment. About 2 months after that, I get an email from her. The email says, Dr. Price, guess what, I'm pregnant. I'm like, I freak out initially. I'm like, did I give her the disclaimer? So I sent her back an email like, congratulations. But she was very happy. She goes, no, you don't understand. She goes, for 2 years before I came in to see you, my husband and I were doing fertility treatments. They had spent like $30,000 out of pocket on these fertility treatments. She was told she could not have kids. She said that she was told it was not a possibility for her. And I said, well, why didn't you mention this to me in the history? I even went and pulled her history intake form, and there was no mention of it. And she said, I didn't mention it because I didn't think it was an option. I didn't think it was something that could happen. So we went through and we worked with her, and we balanced the adrenals and the hormone, or the blood sugar, and as soon as we did this steal stopped happening, so the body started going in the direction that it was supposed to. Those hormones balanced, and within 2 months she was pregnant. And she ended up having twins. And they're adorable. She still brings them into us. I'm so glad she was happy about that. Can you imagine how mad she would have been if she had twins?
I forgot to tell you that.
Yeah, exactly. That disclaimer. It's in writing now. But yeah, and we were not even trying to address hormones. We were addressing blood sugar and adrenals, but the hormone pathway balanced itself. And that's what's really cool when you watch these things happen. There are so many little things that you don't realize that are malfunctioning that start to go away. I had a guy, about 2 weeks ago, we were doing his exit interview he was finishing up treatment, and he asked me, he goes, is it possible that by doing this, I can understand words better? I said, well, what do you mean? He goes, well, he said, for my whole life, I would listen to music, but I've never been able to sing along with music because I could never hear it or understand what they were saying. He said, but the other day I was sitting there and I was listening to music and I was singing, and my daughter said to me, she goes, Dad, you're singing along with the song. And he was like, holy cow. And he realized that he could actually hear the words and turn it into something he understood. And what that is that temporal lobe. Temporal lobe takes sound vibrations and translates it into things that the brain can understand. Well, his temporal lobe was so haywire for so long that he couldn't listen to music and hear the words. He could hear the sound, and that's how he judged music, was by the tone and the sound, but he couldn't hear the words. And for him, he was a great story. He was somebody who came in, his blood sugar was 220, his triglycerides were like in the 5s, like 500 and something, 100 is normal. His cholesterol was over 300, and he was on no medication. He was pure diabetic, but on no medication, and he was a nurse in the emergency room. And I'm like, I was so excited to work with him because we had all these major issues, but we didn't have any medication blocking the healing. And within 90 days, he got that brain recovery. His blood sugar was down to like 120, I think, or 130. Triglycerides were down in the hundreds, right where they should be. Cholesterol was down to about 220 at that point. So he still had a little bit of work to do, but in 90 days, he had totally changed his life. So it was really cool to see that. Okay, sorry, tangent. Okay, so this is in essence the web of physiological dysfunction. Okay, so what does that mean for you? What it does not mean is if you have all of these things, it does not mean that you go out and buy a liver detox, a colon cleanse, a stomach support, adrenal support, and start doing all these different things. And I see that with a lot of patients when they come in our office. One of the things they do is they bring in bags of supplements that they're taking because they're trying so hard, they're Googling and they're just trying the next thing to try to fix it. When you do that, when you start chasing symptoms, number one, you waste money, but number two, you can actually toxify the body because you're doing too much and it's not what your body needs. I kind of liken it to this. I like fire. Okay, I'm not a pyro, but, but I do like fire. So if you take like a metal wastebasket like they used to have in school, and you put a bunch of paper in there and you put lighter fluid on it, I set it right here and I light it on fire. It's going to be kind of cool. It's going to get some good flames going. But if it goes too high and it starts to get close to the ceiling, I'm going to start freaking out. So you got these flames that are spreading, fixing to hit the ceiling. So if that happens, I'm going to run around the corner and I'm going to grab my fire extinguisher and I'm going to come over here. And I have two options. The first one, if I was going after all these symptoms, would be me to stand here and spray up at the flames up here and keep on spraying to keep them back from the ceiling. Okay? I can do that. It's going to work. Fire extinguisher runs out and you still have flames. So it's like if you take a bunch of supplements to try to take all these things and then all of a sudden, you run out of supplements and the problem's still there. Option number two is I come up with a fire extinguisher and I spray into the can and I hit the source and all that goes away. Okay? So you have to figure out what's the source. Just like that patient that had the blood sugar and the adrenals, but then she ended up pregnant. We got the source so her body healed the other areas. So how do you determine what that source is? It's through the testing. So one of the things that we do is a complete blood panel. This blood panel consists of a metabolic panel. It tells us your liver, kidney, organ function, hydrochloric acid levels, so on and so forth. CBC with differential, that tells me how your immune system is functioning. Do you have any deficiency anemias, B12 deficiency, iron deficiency? Do you have anemic symptoms, but you have plenty of iron and plenty of B12? That tells me something completely different. Is your liver processing properly? Is your intrinsic factor in the gut working properly? So these factors give us a lot of information that tell us the metabolic pathways. We run a lipid panel, not because I care what your cholesterol is, but I care how your body's metabolizing blood sugar. Again, you get the blood sugar fixed, that lipid panel goes down quickly. Thyroid panel, most docs run 2 to 3 tests on the thyroid gland. We run between 9 and 13 because we need to figure out where's the breakdown happening. We look at an iron panel, we look at B12 and folate, we look at autoimmune antibodies for the thyroid gland, vitamin D3. There's a lot of different things that we run in this blood panel. Okay, that's number one. Number two, adrenal and hormone salivary testing. So a lot of patients get hormone testing done through blood work. And there's a debate in endocrinology, well, what's better? Is it saliva or is it blood work? Blood work tells us what's available. Saliva tells us what's been metabolized. So I'm of the opinion that saliva testing gives us a more accurate depiction of what the body's actually using. So we use saliva testing for the hormones. We can also test adrenal function with that. Leaky gut testing. You can actually do a test to see if there are these proteins that shouldn't be in the blood. And the cool thing about that is you can rerun the test when you're finished with treatment and make sure you got them. So that's really cool. Food sensitivity testing. So a lot of times patients are eating food that they think are healthy, but their body has an immune response to it. So we can do food sensitivity testing to see what's going on with that. So these are some of the tests that we run. We also do hair sampling, stool sampling, urinalysis, all these different things that need to be done depending on what we find with the patient. I don't even do all these tests on everybody. This is one that we do with most of our patients because that gives us our foundation, and then the rest of it is if we have to dive into more detail. Right? That kind of makes sense. And then once you figure out what that cause is, then you can go in and start resolving this stuff. All right, so reviewing what we discussed, number one, you can't treat based on labels. So I gave you all the example of all three of y'all having hypothyroidism. You've got to treat the patient that has the condition, not the condition that the patient has. So you got to get in there and figure out what's the cause of it. Knowledge and action equals power. So it's got to be the right knowledge for each individual person, and then you have to take action on it. Now, when I say right knowledge, that means, Cheerios does a heart good. You guys ever heard that? Okay. Lies. That's wrong knowledge. So you got to learn how to distinguish what's good and what's accurate. And also, it's got to be right for the individual. I had a guy that was in a workshop with me, and he stands up in the middle of the workshop and he says, "This is great information, but the only thing that you have to do to fix yourself is stop eating at 5 o'clock. He said, "I did this 6 weeks ago. My energy's great. My sleep well. My focus is incredible. I've lost 30 pounds and all these different benefits." I thank him, and he sits down. In that workshop, we had 3 ladies that came in for treatment with us, and all 3 of those ladies, I took it off here, but all 3 of those ladies had hypoglycemia. And what's the worst thing that you can do if you have hypoglycemia? Not eat, exactly. So for him, it worked. That was right for him. For those 3 ladies, it was the worst thing they could have done. So it's got to be the right information for the individual, and you find that with the testing. And then an exit strategy. Like I said, most of our patients we work with 3 months, some of them we have to go to 6 months. But for the most part, my goal is when you're working with a patient, you want to teach them what you're doing, why you're doing it, and teach them the tools and the processes and how to evaluate their health so that 20 years down the road they know what they're doing. And they don't have to be going to the doctor all the time, even in our office. It's like, your life should not rotate and revolve around your doctor's visits. Okay, that's my opinion. All right, so you ask yourself, is the approach that you're doing and trying to handle your physiological dysfunction, is it working for you? Are you satisfied with the results that you got? And then, is the path going to get you where you want to go? And this is the key question, because if you don't feel better today than you felt a year ago, then the reality is today is the best you're going to feel, because a year from now you're going to feel even worse unless you change that path. But the cool thing about it is if you start making different decisions and figure out what's going on, you can change the trajectory. And that's what we do. That's really cool. Just some information about what we do. I like to get the negatives out first. It does take time, it takes discipline, and it does take money. It's worth it in my opinion, but there are negatives. So get those out there. So if you have this kind of stuff going on based on what you saw in the questionnaires, and if you want to dive into it a little bit further, we have a 2-visit new patient process. The first visit, when you come in, we gather up these questionnaires. We have you bring in any labs that you've had in the last 90 to 120 days. We bring those in and I analyze those using functional lab analysis. We have you bring in a written history packet. I have patients write their history, and I do that because number 1, I'm visual, so it helps me go in and read it and I can ask questions about it. And number 2, when you guys are writing your history, it triggers memory. So then we can get into depth of what's happened and what's been going on. A lot of patients will bring in, like, they keep a journal with their history, and those are great because I get all the detail about what's been going on. So I gather all that information from you, and then we also do a neurological evaluation to see how the brain is functioning and what's the brain status. Okay, that happens on the first visit. In between the first and second visit, I take all that information and I analyze it. I'm looking for what's going on with you. How can we help you? Can I help you? If I can't, I won't take your case. I will refer you somewhere else. If I can help you, I look into what treatment options, so on and so forth. So the second visit, when we get back together, first thing we're going to do is go over all your findings. I'm going to let you know if I can take the case or not, but even if I can't take the case, we're going to go over all your findings. So we're going to talk about all of this as it pertains just to you. So that second visit, we spend about an hour talking about just your body. So patients learn a ton in that visit. If I cannot take the case, again, if I don't think I can help you, I'll refer you out, tell you what I think you should do. If I can take the case, then we talk about treatment options, time requirements, finances, and so on and so forth. Okay, so we talk about that on the second visit. One of the questions I get all the time is, does my insurance cover it? And the short answer is, I don't know. The long answer is, when you come in on this first visit, we get your insurance information, and after I've gathered all this information in between the visits, if I think I can take your case, then I'll call the insurance company once I know what treatment and labs we're looking at, and I'll call them and find out what your benefits will cover. And on that second visit, we'll get your out-of-pocket expense down to the penny. So I can answer that question on that second visit. Patients go up front. When we get done in here, they go up front and they ask Katie, well, does this insurance cover it? She doesn't know. We just don't know because everybody is so different. So we'll know that on that second visit. Okay. I wish I could give you a better answer, but that's just where we are with that. I do ask that on the second visit, because we're going to be going over what's going on with you, if there's somebody that's involved in your day-to-day life, decisions, so on and so forth, a spouse, a significant other, a close relative, a friend, I ask that they're there with you on that second visit. And the reason for that is, number 1, we're going to go over what's going on with you so they can understand what you're dealing with. Number 2, if we're getting into treatment, we're going to talk about time requirements, money, and so on. So it's good for them to be there so that they can give their feedback on that, and I can kind of see, what we're working with and everything. One of the worst things to happen, and this just happened the other day, is we spend about an hour together here. I spend about an hour looking at your file in between. We spend about an hour together here, and then we get finished with everything, and I tell the patient, okay, so what are we going to do? And they say, I need to go home and explain this to my significant other. And I'm like, there goes the rest of my hair. Because there's no way you're going to be able to explain what we just went through. So I really do ask that they're there for that visit. If there's not somebody that's important that is involved with that, that's fine. But if there is somebody, we ask to put it there. Okay, so typically the 2 visits are $125. But when you come to a workshop like this, that saves me a lot of talking and explaining in the office. So we do give you a discount. It's $47, okay, and that covers both visits. It's not $47 each, it's $47 total. The catch to it is that you've got to prepay for the reservation, and we want to try to get you to make that appointment within the next 7 days so that we can kind of keep up with the patients that we have coming through. A couple things to consider. Lifestyle changes. I am not a vegan. I am not a faster. I am not a juicer. And I'm not going to ask you to be. I don't live on nuts and seeds and twigs and all this stuff, okay? So I'm not going to ask you to do things that I don't do. But there will be things that have to change to get you to a better place. So you just got to be willing to do that. Take accountability. That basically means that if we ask you to do something, you realize, okay, I have control over my health. If I make different decisions, I can change the direction. So that's all that means. Again, insurance-wise, we'll get that to you on the second visit. Just to give you a ballpark, I have some patients that finish up treatment at $300, $400, $500, something like that. I have some patients whose case fees go over $10,000. Some patients prepay for treatment to get discounts. Some patients like to finance it out. So there's all kinds of different options. As a general rule, if you can afford somewhere between $200 and $400 a month, you should be fine with getting treatment. Okay. All right, if you want to schedule, when you go up front, Katie's going to have the new patient appointment times that we have available. They'll be laid out on little cards. Just grab your card that you want, put it with that little slip of paper that has your information on it. Give that to her, she'll swipe your card or collect payments, and then she'll put you in the computer later. That way, if all 4 of you guys signed up, you'd be out of here in 5 to 10 minutes. So it's a really, really quick process. When you do that, make sure that you get your care binder. That binder is going to have the paperwork that you need for that first visit. On the first page is a checklist of the things that you need to do before you come in for that visit. So make sure you go through and read that and complete that checklist before you come in. And that is it. So what questions